Welcome to Achieving RA Treatment Goals, Real-World Experience, and Emerging Insights in the DMARD Monotherapy. I'm Stanley Cohen. I'm Medical Director at Metroplex Clinical Research Center and a Clinical Professor of Internal Medicine at UT Southwestern School of Medicine in Dallas, Texas, as well as Director of the Rheumatology Teaching Program at Presbyterian Hospital in Dallas. This program is being provided by North American Center for Continuing Medical Education and supported by an educational grants from Lilly and Pfizer. Remember to please complete the post-test and evaluation at the conclusion of the session to receive your CME and CNE credits. Now, the learning objectives for today are to discuss the impact of recent guidance on the role of monotherapy, sequencing, treat-to-target goals, and new therapies in RA management, explore recent real-world data and emerging insights into biologic and non-biologic DMARD monotherapy and the impact on treatment decisions, evaluate the recent and emerging agents, including JAK Inhibitors and their role in the management of RA, and develop personalized care plans utilizing evidence-based guidance, emerging data, treat-to-target, and share decision-making strategies. So I always like to start with a case study. This is a case that's representative of the usual type of patient we see in clinical practice. 55-year-old woman with rheumatoid factor CCP positive rheumatoid arthritis of 6 months duration who had been initiated on methotrexate 20 milligrams weekly, escalated to 25 milligrams sub-Q from oral after 3 months due to continued disease activity. She was also taking Celecox of 200 milligrams daily. She had a past smoking history of 1 pack a day, which was ongoing. Otherwise healthy. She had 5 tender joints and 2 swollen joints on exam. Her CDI, Clinical Disease Activity Index, was 13, indicating moderate disease activity, which had improved from a CDI of 23. Her sedimentation rate was 45, CRP1 both elevated. She was mildly anemic with a hemoglobin 11.2. The remainder of her laboratories were unremarkable. She had baseline hand and feet x-rays because of those joints being involved, and she did have juxtaarticular osteopenia and a single erosion. So there are many different treatment options available for a patient such as this, who's a high-risk patient, seropositive, and already for the presence of erosions. Continuing methotrexate is one option, which is not really the best option with ongoing disease. It's very common to add low doses of prednisone, 5 to 10 milligrams, to calm down the disease early in the disease and might have a disease-modifying capability early in the disease. We could switch to TNF inhibitor monotherapy or abatacept monotherapy or IL-6, tocilizumab or sarilumab monotherapy, or escalate to triple therapy, hydroxychloroquine and sulfasalazine along with methotrexate, or consider something such as tofacitinib monotherapy. Combination therapy with these biologics and targeted immunomodulators could be considered in combination with methotrexate, which is what is generally recommended by the professional societies, both ACR and EULAR, which we'll discuss briefly. So, as with all patients, a benefit-risk discussion of treatment options occurs, going over the various treatment options, and as part of the discussion, the frequency of disease monitoring, the need for laboratory monitoring, is discussed with the patient. The potential for disease progression if therapy is not escalated is also discussed with the patient. The discussion of using parenteral therapy versus oral therapy. In addition, with the therapeutic discussion, the patient is encouraged to discontinue smoking due to the modest evidence that smoking may actually worsen RA, and we know that RA patients have a greater risk of lung cancer, and this puts them at greater risk because of the smoking history, this particular patient. So after this benefit-risk discussion, the patient decided they were willing to self-inject but preferred not to inject weekly, and Adalimumab 40 milligrams every 2 weeks along with combination methotrexate 25 milligrams subcutaneous was continued. Celecoxib is continued for symptomatic relief. 3 months later, the patient was much improved. 2 tender joints, no swollen joints, a SED rate of 20, CRP of 0.8, both now normal. And the CDI was now in the low disease activity range at 6. However, it is not uncommon with our patients. 12 months later, the patient experienced a disease flare, 7 tender joints, 5 swollen joints, elevated ESR at 42 and CRP at 1.5, and the CDI had gone back up to moderate disease activity at 20. So what were our treatment options at that time? Now we have a patient who had failed one biologic plus methotrexate. Certainly adding prednisone is a reasonable thing to consider, and about 40% of our RA patients in clinic, even with our better therapies, are on daily prednisone. We could have switched to leflunomide plus methotrexate, which is a non-FDA approved regimen, but which was shown in clinical trials to be effective. More toxicity can be associated with this, especially hepatic toxicity, so it needs close monitoring. We could switch to triple therapy with hydroxychloroquine and sulfasalazine and methotrexate. We could switch to a second TNF inhibitor as either monotherapy or combination therapy, or we could change the biologic with a different mechanism of action, such as abatacept, tocilizumab, sarilumab, or rituximab, or we could switch to tofacitinib monotherapy or combination therapy. Again, after discussion with the patient and going over the options and the benefit-risk analysis, the patient said, I really don't like to self-inject and requested going on oral therapy. So tofacitinib, 11 milligram extended release, was chosen in combination with methotrexate. By 1 month, the patient had improved, now with only 4 tender and 2 swollen joints. CRP and sed rate had normalized, and the CDI was down to 9. At week 12 and week 24, patient continued to improve. At week 24, 2 tender, no swollen joints, and CDI was at 4, indicating low disease activity. Patient said, I want to get off this methotrexate. Generally, I feel fatigued and somewhat have some stomach upset the day after I take it, along with some hair loss. Methotrexate was slowly tapered over 8 weeks. Unfortunately, the patient's disease began to flare. CDI was now 15. And the patient was willing to try methotrexate again at a lower dose, this time oral dosing, and improved again with combination therapy with tofacitinib. By 8 weeks, CDI was only 4, and combination therapy was continued. So this is a pretty typical type of RA patient that we see who has escalated to biologic therapy, does well initially, loses response, and then is switched to a different mechanism of action, in this case tofacitinib. So let's go back and review before we talk about the present and the future. We learned a lot of lessons in the past 30 years. I've been practicing rheumatology for close to 40 years, and it's a lot more fun to be a rheumatologist these days than it used to be because of the various treatment options we had. It took a long while before we learned that structural damage occurs early in disease and that we needed to treat early. With better outcomes occurred if we treated patients earlier than later due to the lack of structural damage. We learned that methotrexate is an effective therapy and that about a third of patients with early rheumatoid arthritis go into remission or low disease activity, which may be maintained for several years. Because of the ability to put patients into remission or low disease activity measurements were developed and validated and shown to be helpful to assist decision-making in the clinic regarding therapeutic changes. We've learned that these biologic therapies are very effective, but that there is very similar efficacy and safety in combination with conventional synthetic DMARDs, and the degree of improvement is very similar, and that no one biologic is better than the other, and we'll show you some examples of those studies. As I mentioned, patients with earlier disease respond better to treatment than patients with longer standing disease, and that at least in the European and rest of the world model, treat to target, as demonstrated by multiple clinical trials, and we'll show you one example, the BEST trial, is superior to usual treatment, not targeting disease activity measures. This is an older slide. You can see in the footnote that this slide was originally developed in 1990 by Bill Aaron and Jean-Michel Daer. We have taken the liberty of updating this slide to show the various members of the immune system that have been identified to be involved in the pathogenesis of RA, the various cytokines they produce, the tissue destruction that can occur, and many of these have become targets for our therapies that we now use. We have shifted from the use of empirical therapies in the 1980s that we stole from other disciplines to try to treat the disease based on case reports or findings of patients with other diseases who also had RA who improved. So now we have targeted therapies where we can target particular cytokines, proteins, chemokines in the immune system, various cells such as T cells or B cells, and block those, and our results now are far superior to what I had when I first started working in 1979 and 1980. And shown here is a list of the various tools that we now have in 2018. This slide summarizes the disease activity measures that have been validated. This is from a white paper from Dr. Anderson that was an effort by the American College of Rheumatology to provide clinicians with a list of possibilities to measure disease activity. We have patient-driven tools as shown here, the patient activity scales, the RAPID-3, the most commonly used patient scale routine assessment of patient index data with 3 measures, which uses an MD hack and patient global and pain rating. And then we have tools which use patient and provider composite tools, the CDI, the DAS28, or the SDI. In my particular clinic, I use the CDI to monitor disease activity. The ACR and other professional societies feel that just use any one of these, the one you're most comfortable with, as these are useful and validated where you can monitor disease activity and assist in decision-making about changes in treatment. This is a busy slide, but really points out looking at various therapies, whether it be abatacept, a T-cell activation inhibitor, Golimumab, a TNF inhibitor, tocilizumab, an IL-6 receptor monoclonal antibody, rituximab, which depletes B cells. When you're looking at the ACR70 response across these various studies with these therapies, there's really not much difference. Patients who are methotrexate naive, early disease patients tend to be the ones that respond the best. Patients on the far right who are anti-TNF incomplete responders have the least response. So again, these ACR 70 responses, as are the ACR 20 and 50 responses, are all very similar. You see here in gray the background placebo response, and in the different colors the active therapy response. Again, pointing out that all the targeted therapies have similar efficacy. We also know from the few head-to-head trials that have been done, this was the Accelerate RCT, looking at ACR 20 response on the y-axis, comparing certolizumab to adalimumab, both with background methotrexate, and really no difference in ACR response, and no difference in the number of patients achieving low disease activity by DAS28 response. So again, 2 different TNF inhibitors with very similar clinical response. This was the AMPLE study looking at sub-Q abatacept compared to adalimumab, and the usual dose is 40 milligrams every 14 days. Again, on the y-axis, the proportion of patients with an ACR 20 response. You can see the numbers are very similar. No differences in the ACR 20 response between the 2 groups. Now, if you take monotherapy, we know that adalimumab, and based on some data I'll show you a little later in the discussion, is more prone to be associated with anti-drug antibodies, that if you take on adalimumab monotherapy, you can beat that. And that's been shown with the sarilumab here, which looking at the DAS28 ESR and the DAS28 CRP change over 24 weeks, looking at the least square mean change from baseline on the y-axis, you can see that in the orange that sarilumab 200 milligrams every 2 weeks was superior to the standard dose of adalimumab. So this is a situation where there is a difference in biologics, potentially with monotherapy, and this has been shown for tocilizumab compared to adalimumab as well. So guidelines have been developed and have been edited and updated for several years now. This is the ACR 2015 guidelines, taking a look at early RA patients with low disease activity or moderate or high disease activity. And again, the treatment is initially a DMARD monotherapy, generally methotrexate. And those patients have moderate or high disease activity. again escalating quickly to TNF inhibitor plus or minus methotrexate, or non-biologic non-TNF biologic inhibitor plus or minus methotrexate. If continued disease activity is present 3 to 6 months into treatment with DMARD monotherapy. Treat to target, again, has been adopted by the ACR as a concept for treatment in the clinic, and that also is similar to this very complicated slide here from the EULAR recommendations for management of RA. This is generally very similar to the ACR guidelines. Again, clinical diagnosis of rheumatoid arthritis, generally start methotrexate unless there's a contraindication. The Europeans are more aggressive with short-term glucocorticoids. If you achieve improvement at 3 months and target is 6 months, continue what you're doing. If not, go on to phase 2, which is adding biologic DMARDs or a JAK inhibitor, or changing to or adding a conventional synthetic DMARD, and then progressing to phase 3 with different mechanisms of action. If again you failure to achieve improvement at 3 months or your target at 6 months. So little different semantics, but very similar overarching guidelines. So let's drill down into a number of these topics over the next 40 minutes. Let's talk about the role of treat to target. Treat to target initially was a concept that was very exciting based on TICORA study in the UK, which demonstrated that targeting disease outcomes was far superior than usual treatment. A subsequent study which impacted many of our beliefs about treatment was the BEST study. There have been multiple publications from this observational outcome study. 508 patients with RA with very short duration of disease, symptoms 23 weeks, were randomized to 4 different therapeutic strategies. Treat to target every 3 months by a nurse who was monitoring the patients. If their disease activity was not in low disease activity, their therapy was escalated. They could be withdrawn from therapy after year 2 if they were in remission, which was defined as a DAS-44 less than 1.6 for 6 months on monotherapy. These are the 4 categories of therapy. Monotherapy, which is what used to be the old way we used to treat, cycling from one DMARD to another. Step-up therapy, patients on methotrexate escalated to sulfasalazine, then triple therapy, then prednisone could be added, and eventually they could end up on infliximab plus methotrexate. Combination therapy using low-dose methotrexate 7.5 milligrams, low-dose sulfasalazine plus 60 milligrams of prednisone with tapering of prednisone to 7.5 milligrams over 8 to 12 weeks. And then again, they could be escalated to cyclosporin or infliximab plus methotrexate. And the last category was starting with high-dose methotrexate 25 milligrams, 3 milligrams per kilogram infliximab, escalating all the way up to 10 milligrams per kilogram if necessary, and then other treatment alternatives if patients were not in low disease activity. And this was their 5-year data. They've presented their 10-year data, which is similar to this. At 5 years, 48% of patients achieved remission. These were people with very early disease, rheumatoid arthritis. Drug-free remission would range from 10% to 19% from group to group. You can see from the graph looking at the mean HAQ score that greater improvement was seen in the first 6 to 12 months in combination with prednisone, in combination with infliximab, and then over time there was a modest difference between the groups. And when you look at radiographic progression, clearly there was less radiographic progression, as shown here, mean modified sharp score progression, lesser progression with the initial combination with prednisone, initial combination with infliximab, as you would expect due to the progression that occurred in the first year or 2 of study, but after that there was leveling off of the progression. So overall, targeting disease activity, acting on that disease activity, was associated with long-term improvement in disease activity in a significant percentage of patients who developed remission. There was modest additional improvement with high-dose steroids initially or biologic therapy that was seen over the first couple years of treatment. This was the DREAM cohort, a Dutch cohort of patients these were patients initiating their first TNF inhibitor, and they had 1,115 visits of patients in their cohort, of which 97.9% had disease activity measured, 88.3% had disease activity measured every 3 months, So very compliant physicians, nurses. In patients not in remission, 57.9% had their therapy advanced. Adherence to the treatment advice was present in close to 70% of patients. 30% of patients chose not to escalate their therapy due to concerns over adverse events. Patients felt they were doing well enough. They had accommodated to their disease, or it was a clinical decision made by the physician. So this is an example of real-world treat-to-target phenomenon, how often patients are willing to advance their treatment or not. So one thing that's of interest is that most of the treatment, if not all the treatment target studies, have been conducted in the Europe or rest of the world. The European healthcare system is different from the United States healthcare system in that many patients rarely see the rheumatologist due to the fewer number of rheumatologists available, and are frequently seen by nurses or advanced care nurses who treat the patients. In the United States, patients are generally seen by a rheumatologist, now in conjunction with a PA or an NP, but the rheumatologist is making the ultimate decisions. And in general, it's been my experience when patients are in pain or have active disease, they're seen much more frequently. So CORRONA, which is a North American observational registry, conducted a study where they had 14 sites in each group. He had 14 sites that provided usual care. Patients had to be seen every 3 months as part of the study. They could be seen more often than that, but they had to be seen every 3 months. Then you had a treat-to-target group, 14 sites with cluster randomization, where patients were seen every 3 months but had to be seen more frequently if their CDI was greater than 10, indicating moderate disease activity. The groups in the usual care treatment group were told that there was a treat-to-target comparison group, which may have influenced their treatment as well. What was seen in this particular study, when they looked at the primary outcomes, which was the feasibility of escalating the dose, actually increasing the dose for people who had CDI scores greater than 10, there was no difference between patients in the usual care or the treat-to-target paradigm. So even though the treat-to-target paradigm was instructed to increase treatment, there was really no increase in the dose compared to the usual care. And looking at the primary efficacy outcome, which was the percent of patients in low disease activity, and secondary efficacy outcome, which was a completers analysis, patients who actually completed every visit, there was no difference in the frequency of patients who achieved low disease activity. So what this suggests is that in North America, the way we practice, because our patients are used to seeing their rheumatologist more often, at least in these particular clinics, that treat-to-target and usual care may not be that much different. Certainly, however, it may be different in Europe and the rest of the world. So measuring disease activity is important and should play a major role in informing decision-making regarding modifying treatment. It also, from a pragmatic standpoint, satisfies requirements for CMS quality outcomes and MIPS and macros and things of that nature. Treat-to-target certainly has resulted in improved patient outcomes in Europe and the rest of the world where access to the rheumatologist is limited. It's unclear what added value it provides to RA management in North America, but it is here, at least we're thinking about disease activity scores, we're measuring disease activity scores, and certainly I think it does provide some additional information for us to make a decision on how to proceed with treatment. So let's move on to the second topic, biologic monotherapy versus combination with conventional synthetic DMARDs. So just a polling question. First polling question, biologic monotherapy is as effective as combination therapy. Is this true or false? So what about biologic monotherapy? We know that from observational registries and claims-based analyses, 30% of patients with RA take biologic monotherapy. The studies have suggested that this is primarily due to adverse events, such as, methotrexate, where patients just feel poorly on methotrexate, or leflunomide, where they might develop a rash or hypertension or LFT abnormalities. Patients' unwillingness or noncompliance. And then there are patients where we try to withdraw therapy, patients in remission or low disease activity, and some may choose to withdraw the conventional synthetic DMARD first before withdrawing the biologic. We have data that has to support monotherapy efficacy has been reported from randomized clinical trials as well as observational registries. Most of the studies have suggested that conventional synthetic DMARD incomplete responders do better with combination therapy with the biologic plus conventional synthetic DMARD than biologic monotherapy. So let's show you some of that evidence. This was one of the first studies which unequivocally demonstrated that combination of etanercept plus methotrexate was superior to etanercept alone compared to methotrexate monotherapy. This was a large trial, a multinational trial, that looked at patients receiving methotrexate up to 20 to 25 milligrams, mean dose 15 to 17 milligrams a week, compared to etanercept 50 milligrams weekly and divided doses 25 twice a week, or etanercept plus methotrexate. Shown here are the last observation carried forward, LOCF, or a completers analysis, and we'll focus on the LOCF. And looking at the disease activity less than 2.4, or disease DAS28 less than 3.2, low disease activity measures, or remission, shown here. Just you can scan down here and you can see that for etanercept plus methotrexate, for whatever criteria you're looking at, LDAS, low disease activity, or remission, etanercept plus methotrexate was superior to methotrexate monotherapy or etanercept monotherapy. Now, etanercept monotherapy and methotrexate monotherapy in these studies were not greatly different from each other. There began to be some separation over the second year of therapy, but not at the first year. So again, unequivocally, combination therapy was better than monotherapy in this study. Looking here at this cumulative probability plot of radiographic progression, and we have looking at the Van der Heide-Sharp score, looking at the change from baseline on the y-axis, you can see that in combination therapy in the gray, there was less progression of Sharp scores than there was with etanercept, which was slightly better than methotrexate monotherapy. And again, the y-axis is the change in Sharp score, the number of units. So again, radiographically and clinically, combination therapy was better than etanercept and methotrexate monotherapy. Not to say that etanercept and methotrexate monotherapy were not effective. They were. Similar study, early disease, looking at adalimumab in the standard dosage, 40 milligrams every 14 days, along with methotrexate versus methotrexate monotherapy and adalimumab monotherapy. On the top of this slide, you see the ACR20, ACR50, and ACR70. Again, you can see that numerically and statistically, combination therapy was better compared to monotherapy with adalimumab and methotrexate. And you can see that the total Sharp score on the bottom right, again, combination therapy was far better than methotrexate monotherapy, 10.4 progression over 2 years compared to 5.5 for adalimumab, and only 1.9 for adalimumab plus methotrexate. So again, this confirmed the experience with etanercept and methotrexate. Polling question number 2. Which of the following therapies is associated with a higher likelihood of anti-drug antibodies? Abatacept, A. Adalimumab, B. Etanercept, C. Tocilizumab, D. Shown here is a study published in JAMA from 2011, Bartels and his group from the Netherlands, and showed that over 3 years of follow-up in patients receiving adalimumab for rheumatoid arthritis, 28% of patients developed anti-drug antibodies. And associated with these anti-drug antibodies was a drop in trough levels, serum trough levels, and also loss of response and an increase in adverse events. What they also showed in this study, highlighted in yellow, is that patients who received methotrexate were less likely to have antibodies to adalimumab than patients who did not. And so clearly methotrexate reduced the likelihood of anti-adalimumab antibodies and this resulted in a better clinical response. This is something we knew from the phase 2 and phase 3 clinical trials of adalimumab, where using old methodology, we now have much more sensitive assays for anti-drug antibodies. 12% of people on monotherapy with adalimumab developed anti-drug antibodies, and only 1% on combination with methotrexate. So a very important teaching point, which I think most rheumatologists are aware of. Now, other biologics are less immunogenic, have less anti-drug antibodies. So this is a study where they took patients on methotrexate and added tocilizumab to methotrexate, which was shown here in the reddish-brown color, or they took people and just stopped the methotrexate and put them on tocilizumab. And so you had two groups, tocilizumab plus methotrexate, or tocilizumab plus placebo. Patients were followed for 24 weeks and then 52 weeks. And what they found at 6 months, there was no difference here in patients in DAS28 remission, as shown here on the left part of the slide. But at 52 weeks, patients on combination therapy had a greater frequency of DAS remission with a trend towards statistical significance. When they looked at radiographic outcomes, radiographic progression in the standard fashion, you can see at week 24 there was no difference in radiographic progression between those continuing methotrexate and those who went off methotrexate. But at 52 weeks, again, there was a slight difference and statistically significant difference in radiographic progression for those on combination therapy, suggesting that monotherapy with tocilizumab is effective, but the combination therapy, again, is moderately better in a head-to-head study. Shown here was the frequency of antibodies, anti-drug antibodies, and those which were neutralizing to tocilizumab, and you can see a much lower frequency here than what we see with with monoclonal antibodies, such as adalimumab and infliximab. A more recent study, which is quite interesting, was a study in The Lancet looking at tofacitinib and taking methotrexate incomplete responder patients and randomizing them to take tofacitinib 5 milligrams BID monotherapy, or tofacitinib 5 milligrams BID plus methotrexate, or adalimumab 40 milligrams every 14 days plus methotrexate. Patients had to have active disease to enter the study and were considered methotrexate incomplete responders. This was a non-inferiority global study, and the primary endpoint was the ACR 50 response. And what you can see here numerically is that the ACR 50 response for combination therapy in the dark gray and yellow was better than the light gray tofacitinib monotherapy, and the similar trend for ACR 20 and ACR 70 responses. When a non-inferiority analysis is performed, you can see in the red box that tofacitinib 5 milligrams BID plus methotrexate compared to adalimumab plus methotrexate fell within the non-inferiority margin of minus 13%. When you take a look at the monotherapy with tofacitinib 5 milligrams BID can be either compared to adalimumab plus methotrexate or tofacitinib plus methotrexate, non-inferiority was not obtained. So again, you saw very robust clinical response, but this study demonstrates that combination therapy, again, was moderately better than monotherapy in this population of methotrexate incomplete responders. Finally, looking at observational registry data, this again is the DREAM registry, the observational registry in the Netherlands for patients initiating TNF inhibitors. Looking at a Kaplan-Meier curve, the y-axis is cumulative TNF inhibitor drug survival over 4 years. Brown on the bottom is TNF monotherapy. The yellow on the top is TNF inhibitor plus methotrexate alone. And you can see significantly different rates of persistence on therapy for those on combination therapy compared to patients on TNF inhibitor plus monotherapy. Again, supporting the randomized clinical trial data suggesting that combination therapy in general is superior to monotherapy. So to summarize, superior efficacy for biologics plus conventional synthetic DMARD therapy to biologic monotherapy. Biologic monotherapy does inhibit structural damage better than conventional synthetic DMARDs, but not as effective as combination therapy. Infliximab adalimumab treatment associated with significant anti-drug antibodies and should be administered with conventional synthetic DMARDs if possible. Biologic monotherapy, however, is appropriate where conventional synthetic DMARDs are contraindicated or the patient is unwilling to continue on treatment. So the third topic I want to discuss is how to approach TNF incomplete responders. There have been a few randomized clinical trials to determine what happens to a patient who fails initial TNF inhibitors. One of these studies was the Go After trial with Golimumab, phase 3 multi-center randomized trial, placebo-controlled, 461 RA patients with active RA, despite previous treatment with at least one anti-TNF inhibitor. 24-week study, placebo, Symphony, Golimumab, 50 milligrams monthly in the dose that we used in clinic, and the 100 milligram dose, which is not used in clinic. And they looked at the proportion of patients achieving ACR 20 at week 14, which was their primary endpoint. So in these patients who had failed a previous TNF inhibitor, this RCT demonstrated that the ACR 20 response was statistically better than continuing placebo in these patients on background methotrexate, and demonstrated that in patients who failed a TNF inhibitor, you could achieve a reasonable clinical outcome with a second TNF inhibitor. Looking at abatacept in patients who had failed TNF inhibitors, this study showed that the ACR 20 response in patients switching from 1 to 2 or 3 TNF inhibitors that they had failed was 50%, ACR 50 of 20%, and ACR 70 of 10%. So again, demonstrating that switching to a different MOA, you could achieve a good clinical outcome. This study looked at rituximab in patients who were TNF inhibitors, and again, you see an ACR 20 response of 51% compared to ACR 50 of 27%, and ACR 70 of 12%. Again, a delta of the ACR 20 of about 30%, similar to what we've seen in other TNF incomplete responder studies where different MOAs are initiated. This is a study with Baricitinib, a JAK inhibitor approved in Europe, looking at 2 and 4 milligram doses in brown and yellow compared to placebo in gray, and looking at ACR 20 response, DAS28-CRP, HAQ-DI, SDI definition of remission. Again, Baricitinib at both doses, a slight dose response noted here, was superior to placebo in patients who had failed previous TNF inhibitors. There have been observational studies as well which have suggested we might be better off in switching to a different MOA, mechanism of action, compared to a different TNF inhibitor. This was a study in Annals of Rheumatic Disease in 2015 that looked at patients who either switched to Rituxan or a second TNF inhibitor after an inadequate response to initial TNF inhibitor. Large number of patients, but again, observational registry, and therefore you have to be concerned about the selection bias that could occur, but suggested that those patients who had loss of efficacy to a TNF inhibitor had a better response to rituximab with a change in DAS28 ESR of 1.7 compared to those who went to an alternative TNF inhibitor with a change in DAS28 of minus 1.3. So this was suggestive data, but again, there was a lot of skepticism because this was an observational registry and these patients were not randomized appropriately. And a subsequent study was published in 2016 to give us greater confidence in suggesting that maybe going to a non-TNF inhibitor versus anti-TNF treatment might be better. This was a study, again, in Europe where physicians who had a patient who failed an anti-TNF drug were allowed to pick any other drug that was a non-TNF inhibitor or a TNF inhibitor, depending on how their clinic was participating in the trial, and patients were followed. And this is a very, very busy slide, but we'll focus on the DASH remission here, the bottom part of the slide. When you take a look and follow down the non-TNF biologic group, different MOA, compared to the second anti-TNF inhibitor group, you can see numerical differences that were statistically significant, p-values met statistical difference And again, this was also seen for low disease activity in the EULAR good or moderate response. You can look at the p-values on the far right of the slide. So this study, which was a randomized controlled trial, did demonstrate that switching to a different MOA might be superior to continuing a TNF inhibitor in a patient who had failed initial TNF inhibitor due to lack of efficacy. So to summarize this data, and there are many, many more studies. We don't have time to show you all the studies. Switching to a second TNF inhibitor in an RA incomplete responder is appropriate based on the clinical trial data. Switching to a second TNF inhibitor is less effective in primary non-responders than secondary non-responders in data we didn't show you today. Shifting to a different mechanism of action based on observational data and a limited number of RCTs is possibly more effective than switching to a second TNF inhibitor. So the final topic we want to cover is the newer oral targeted immunomodulators. Where do they fit in the treatment paradigm? So we have had over the last several years Janus kinase inhibitors introduced to the market. We'll possibly have a second one on the market in the near future. Two others are in clinical trial development. These are oral inhibitors of signal transduction that modify inflammatory cytokine production. Shown here is a cartoon depiction, a very simplistic cartoon depiction of these intracellular protein tyrosine kinases that play a major role in signal transduction after ligand binding to the receptor on the cell surface. These facilitate transduction of these signals to the nucleus where the gene transcription is upregulated and various peptides, proteins, cytokines are generated. A number of these have been looked at. P38 MAP kinase inhibitors failed in the clinic. Spleen tyrosine kinase inhibitors have failed to date in rheumatology but are available in oncology. PI3K inhibitors, again, are used in oncology for lymphoma and leukemias but have failed in RA. NF-kappa beta have not moved forward in clinic to date, and the JAK inhibitors we're going to discuss in some detail. Again, we mentioned these tyrosine kinase inhibitors. 9 of these have been identified. There are a couple of these that are receptor protein tyrosine kinases, platelet-derived growth factor, epidermal growth factor receptor. The non-receptor PTKs are what we're interested in. There's significant experience with these drugs in oncology, multiple approved therapies, including imatinib, Gleevec, which has been used for years in oncology. JAKs, Janus kinases, are critically important to transverse phosphase from ATP to other peptides to upregulate STAT proteins, for example, signal transduction and transcription proteins. Jakinibs, the JAK inhibitors, block the ability of ATP binding to these peptides, and therefore you cannot, protein phosphorylation is blocked, and this is how it blocks the inflammatory process. This is the summary of what we know about the cytokine signal transduction pathways, type 1, type 2. This does not include TNF-alpha and interleukin-1. Their JAKs will facilitate signal transduction in pairs. You see here JAK1, JAK3, JAK1, JAK2, and so on in the slide. These various type 1 and 2, type 2 cytokines will signal through these peptides intracellular and upregulate the JAK-STAT pathway. So we have therapies that inhibit JAK1 and JAK3, JAK1 and JAK2. In vitro and some ex vivo assays suggest there's a preference for one JAK over another JAK. We know that in general, tofacitinib is more of a pan-JAK inhibitor, but has been shown to have a reasonable safety profile, which we'll discuss briefly. Baricitinib is a preferential JAK1, JAK2 inhibitor, and those therapies in development, filgotinib and upadacitinib, are more preferential JAK1 inhibitors. How that plays out in the clinic is yet to be determined. Will there actually be a difference in these therapies and their clinical efficacy and clinical safety? And that will be data that will obviously roll out over the next several years, and hopefully we'll see some head-to-head trials of these therapies. Again, tofacitinib was approved in 2012, and by the FDA, it was approved in Europe in 2017, and more than 100,000 patients have received treatment. Briefly going to highlight the studies. There were very large clinical trials, and again, you'll see similarity between the tofacitinib and baricitinib trials, and when the data rolls out in greater detail with the other two JAK inhibitors in development. It's almost an identical trial design. They looked at methotrexate incomplete responders, both looking at clinical data and X-ray data. They looked at DMARD incomplete responders, of which most of these were methotrexate incomplete responders, the SYNC trial. They looked at methotrexate incomplete responders and used an active control, Adalimumab, compared to tofacitinib plus methotrexate. They did shorter duration studies looking at TNFi incomplete responders, and then patients who had been on conventional synthetic DMARDs, they just withdrew them and put them on tofacitinib monotherapy. Bottom line with this slide, looking at all of these clinical trials, this is the ACR 50 response on the y-axis with tofacitinib 5 milligrams BID in the lighter brown, orange in the 10 milligram BID, the dose that is not an approved dose in the United States or Europe at this time. In the darker brown, placebo in gray, adalimumab in yellow. And what you see is very robust ACR 50 responses. This was also mirrored by the ACR 20 and 70 and low disease activity and DAS remission. So no question that these drugs are effective in rheumatoid arthritis. Radiographic outcomes, there was some controversy initially in the methotrexate IR population that the 5 milligram dose did not achieve statistical superiority. Looking at the primary analysis shown up here, a reduction in sharp progression score from 0.47 to 0.12, placebo being 0.47. Various sensitivity analyses were done which suggested it was superior. And then there was an early RA trial comparing tofacitinib 5 milligrams BID to methotrexate in methotrexate naive patients and demonstrated statistical superiority in radiographic progression and received a claim from the FDA. This data is shown here. This was the oral START trial looking at early disease patients, which had a co-primary endpoint of ACR 70 response, which is highlighted in red, where both the 5 and 10 milligram dose were statistically superior to methotrexate. And here shown here is the radiographic data. Again, both the 5 and 10 milligram dose were statistically superior to methotrexate with less radiographic progression. So we know a great deal about tofacitinib. The indications are shown here for moderate to severely active RA with inadequate response to one or more DMARDs. Again, we now have an extended release formulation which was approved in 2015, 11 milligrams. Can be used as monotherapy or with conventional synthetic DMARDs. Short half-life. Its excretion is by the liver and the kidney. In patients with severe hepatic disease or renal insufficiency, the dose should be reduced. It is a teratogen. It should not be used in females of childbearing potential who are not an oral contraceptive. It's also been approved for psoriatic arthritis. It's being studied for other conditions, which are shown here. Baricitinib, again, a JAK1, JAK2 inhibitor. Similar trial design looking at methotrexate naive patients, incomplete responders, and TNFi incomplete responders. This is a drug that has been approved in Europe and around the world, but not yet approved by the US FDA. Again, in similar fashion to the slide I showed earlier, this is ACR 20, 50, and 70 response looking at methotrexate incomplete responders. There was also an adalimumab comparator in yellow here compared to the brownish yellow, which is baricitinib, and placebo in gray. You can see again, very effective drug, ACR responses like we've seen with biologic therapies, and very similar to that seen with adalimumab. As far as X-ray progression, looking at a cumulative probability plot, you can see that adalimumab and baricitinib in these methotrexate incomplete responders were superior to placebo with less radiographic progression and fewer patients having any evidence for change in sharp scores. In DMARD naive patients, again, looking at baricitinib 4 milligram monotherapy or 4 milligram split methotrexate combination therapy, both of these were statistically superior to methotrexate at week 24 and week 52. Baricitinib 4 milligrams with methotrexate was superior as far as radiographic progression compared to methotrexate, whereas the monotherapy dose of baricitinib did not achieve statistical superiority, but did achieve a trend. So baricitinib, this is the indications pharmacology, a little longer half-life than tofacitinib. The 2 milligram dose will be approved, most likely has been approved in Europe for patients with renal insufficiency in the elderly, and I suspect the same thing will happen here in the United States when this drug is approved. It is also a teratogen, so this should be avoided in females with childbearing potential not using oral contraceptive. It had a positive phase 2 study in lupus, and studies will be conducted phase 3 in lupus. It has studies ongoing in psoriatic arthritis and ankylosing spondylitis, which have been positive as well, and is also being looked at in diabetic nephropathy and atopic dermatitis. Polling question 3, JAK inhibitors have similar safety profiles to those of biologics, except for which of the following? Herpes zoster, malignancies, serious infectious episodes, and tuberculosis. So we know a great deal about the JAK inhibitor safety. There's really no difference in the JAK inhibitors and the biologics as far as the rate of serious infections. There is a difference in herpes zoster, maybe a slight difference in opportunistic infection with the multiple cytokines that are being inhibited. There's no difference in TB. We need to screen for TB in these patients. Like the other IL-6 inhibitors, since the JAK inhibitors do block IL-6 expression, there is an increased risk of cholesterol in 15 to 30% of patients. There does not seem to be any increased risk of cardiovascular outcomes based on the studies to date, similar to seen with tocilizumab and their outcome studies. There are elevations in LFTs that occur more often in patients on methotrexate, and the therapies need to be modified. GI perforations occur about the same rate as tocilizumab and sarilumab. And then there's this concern about the increased risk of thromboembolic disease, which we'll discuss briefly. This is a slide from the FDA Advisory Committee for tofacitinib, comparing it to published RCT data on biologics, showing the 5 milligram dose in light gray and the 10 milligram dose in the square in dark gray, and showed no difference in these various adverse events of special interest, except for that with herpes zoster seen on the right, where the rate was over 4 per 100 patient years compared to a mean of about 1.5 to 2 per 100 patient years for biologics. This is a complicated slide. Again, I suggest you go back and review the abstract by Mark Genovese at the ACR meeting in 2017. The highlighted area in red shows on the far left the placebo-controlled trials. There were 5 DVTs, or pulmonary emboli, in patients on baricitinib, and none on placebo in these 6 studies up to week 24. This raised a red flag with the FDA. They are now holding an FDA Advisory Committee meeting later this month on April 23rd to look at this issue, to try to determine, is this spurious, bad luck, or is there something to suggest that these drugs may be associated with increased risk of pulmonary emboli or deep vein thrombosis. This was not seen with tofacitinib. There were some concerns with upadacitinib, but there are many more data points to come from those trials. So we're excited the FDA is going to hold a meeting to discuss this. Clearly, the European authorities did not think this was of major concern. From a pathophysiology standpoint, no one has come up with a plausible explanation why this may occur. As far as laboratory changes, we talked about LFTs and lipids. Hemoglobin reductions can rarely occur if significant JAK2 activity is impacted. You need to watch the neutrophil count and the lymphocyte count. Again, this is part of the mechanism of action of these drugs, and certainly for patients who have significant lymphopenia, dose reduction or discontinuation needs to be considered due to the increased risk of serious infectious episodes. Small, non-significant elevations in serum creatinine have occurred, and there have been no cases of renal insufficiency occurring except in those who have an obvious explanation for other etiologies. So, in summary, combination JAK inhibitors, conventional synthetic DMARDs demonstrated similar efficacy and safety to biologics and conventional synthetic DMARDs. We're looking forward to information. Will the more selective JAK inhibitors develop to have different clinical efficacy and safety? We're surprised that the uptake of tofacitinib has been not as great as we otherwise thought it would be, but it seems to be growing in utilization now after physicians and clinicians become more experienced with the drug. And with a significant advantage over methotrexate as monotherapy, combination therapy in early RA, should we use as initial therapy? Our hands are tied by insurance companies and third-party payers, but certainly with the evidence we have with the two JAK inhibitors, it would seem like this might be a good choice of initial therapy. So to conclude, measurement of disease activity is important to monitor response to treatment. A pragmatic approach to altering treatment is necessary using shared decision-making between the patient and provider. This shared decision-making is reflected in the frequent lack of treatment modifications despite continued mild to moderate disease activity. Combination therapy with biologics or targeted immunomodulators with conventional synthetic DMARDs are generally superior to biologic or targeted immune monotherapy. However, data with monotherapy demonstrate efficacy and aren't appropriate for patients in whom conventional synthetic DMARDs are contraindicated, or if patients prefer to not take conventional synthetic DMARDs. Targeted immunomodulators such as tofacitinib and baricitinib have demonstrated comparable efficacy and toxicity to biologic therapies. They are appropriate as first-line treatment for conventional synthetic DMARD incomplete responders. Thank you for your attention. This concludes the presentation. Please complete your post-test evaluation to get your credit.